So usually an alcohol pad is sufficient. I'm a little neurotic about germs, so I share my neuroses with you.
Hi, Dr. Ray.
Hi, how are you?
So good for you to be here.
My pleasure. Yeah, it's nice to meet your audience, and hello to everybody at home. I'm Dr. Paul Rai. I'm a physiatrist specializing in physical medicine and rehabilitation. And I'm here with Tracy Ann, talking to her about how we're going to manage her spasticity after her stroke that has affected her left side. So I'm very happy to meet all of you guys.
You're learning. Okay.
Okay, so we're talking about how things went last time.
Yeah.
When we did the injections, and I know you had a great response to it. Maybe even a little bit too great.
Much.
Yeah, a little bit too great. So we used 1,300 units of the medication last time, and based on our conversation at your follow-up, we had said we wanted to drop it down a bit to just about 900 units. Correct?
Yes.
All right. So we have 900 units of the Dysport ready for you today. I'll show the audience how we prepare it in just a moment. And we're going to go ahead and target the left arm again.
And you mentioned the shoulder.
The shoulder as well.
Yeah,
correct.
Because I'm not getting up here.
Going to target the muscles responsible for movement of the left shoulder, in particular your pectoralis. Going to target the muscles responsible for movement of your fingers and of your elbow as well. So we've signed the consent sheets, which is very important. You always want to make sure that your provider gives you a chance to ask questions and give you what they call informed consent to make sure that you're comfortable with the procedure and that you're aware of the risks versus the benefits and the potential alternative treatments available to you as well.
Tried another medication and I had no positive effects, and it made me feel like I had the flu for like 4 days. So you were the only one who mentioned Dysport to me.
Yes.
So I'm really thankful for that. Because
I'm happy. Of course, I'm happy to help. One of the interesting things about how we manage spasticity is that there are a lot of different options available. And we talk about medications. Some medications are taken orally. Some medications are used topically on your skin. And then there are other medications that are used by way of injection. The neurotoxins, of which Dysport is one of them, are those types of injectable medications. And when you're talking to a provider or physician about how they're going to manage your spasticity, and for the audience, spasticity is one of the potential consequences after a patient has a stroke, or after a person has a stroke. Depending on the type of stroke you have, usually the limb is very flaccid or loose or weak.
Well, this one was really tight.
It's very flaccid or weak at the beginning, right after the stroke, and then over the course of weeks to months, very often patients will develop tightness of that limb, which we refer to as increased tone or hypertonia or spasticity.
Yeah. I never used the word spasticity. I just said it's really tight, and it was in a fist. But that's the technical term.
Yes, yeah, exactly. And that's how it feels to you, right? You know, spasticity is just a fancy word for feeling tight
no use at all.
And the spasticity or the tightness can very often worsen dysfunction, worsen the ability to use that arm. So, for example, your arm was weak at the beginning, and then it got tighter, and I can imagine that tightness made the use of the arm even worse than the weakness.
The only thing that benefited me was I had more strength in my arm, and since Dysport, I see that that's kind of weaker.
Absolutely,
because I things up here to me. And now I just drop it.
So that you're raising a very, very important point of consideration, which is that the spasticity mimics muscle tone. It's not true muscle tone, but the way I would describe it is the tightness in that muscle very often disguises itself as strength in the muscle, but it's not true strength. It's actually just rigidity. And what happens is as we weaken those muscles to regulate the spasticity, we can expose true underlying weakness that then needs to be strengthened by way of physical therapy or occupational therapy. And that's the goal. So, and along the way, you have to play around with dosing. Don't overdo the management of the tone to the point where you lose any of that rigidity that was actually, we don't want you to lose any of that rigidity that was actually functional for you. So we evaluate and then we speak to the patients to try to titrate or balance the effect, to the benefit.
Third injection. And I normally get it on my left leg and the ankle as well, in the calf. But having just had a total knee replacement, we're not going to touch that
Exactly. Yeah. It's a little off limits for the time being.
Yeah.
Not that it would be necessarily terribly dangerous, but why mess with things as you're still healing?
Yeah.
So we don't want to introduce any unknown variables or factors as you're still healing from the orthopedic surgery. And just for the audience, so they know what we're doing, what I'm doing now is called reconstituting the medication. So the neurotoxin comes more or less dried out in the vial or desiccated, and you have to reconstitute it with normal saline to turn it into a solution that is then injectable.
That's interesting. I didn't know it came mailed to you like that.
And it has to be refrigerated the entire time, so it's kept cool.
The drug company or the insurance company, Accredo, they called me and asked me where I want it delivered.
Yeah.
And I said, no, please deliver it to the doctor's office.
Yeah. We've had it delivered to patients' houses before, and it's a little tricky because it's ultimately your medication. So they're going to mail it to your home just like they would any other medication. The issue, though, is it has to be kept refrigerated, and most often patients don't know that. So it comes in dried ice, so it keeps it cool. But that dried ice will only last a few hours. And if the box is left outside, the dry ice will eventually evaporate, and then the medication can potentially spoil. So we prefer that it gets shipped to us and we keep it under refrigeration for you.
I'm glad I realized that. No, send it to the doctor's office. No, this is very informative, just the whole process.
Great. Yeah.
It's interesting.
Very interesting. I'm going to, whenever I can remember, I'll talk directly to the audience. But, my drama classes at college are coming back to me. I'm realizing when I look at the camera, I'm breaking the fourth wall. And I don't know if that's allowed in your
drama.
Well, sort of.
Elective?
Yeah. Drama seemed to have found me.
Well, you're a natural.
I don't know about that, but my apologies for breaking the fourth wall. It doesn't suit your directorial objectives.
That's so funny. You are an amazing guy.
I don't know.
I have to say.
But thank you for appreciating that.
Now, you started a podcast, but you kind of put it on pause.
Yeah, there's all these great ideas that get floated around, and I love the idea of being able to connect directly to patients in these new and creative ways. I am quite camera shy, actually. I am. I'm a very shy guy. Nobody can tell that anymore, but by nature, I am very shy. I've worked hard on trying to not be that way, but by nature, well, thank you. So, but by nature, I am very shy. So I always hesitate about being in front of the cameras.
Me too.
But I think it's a great way, this direct approach to communicating with patients.
Well, anytime you want to come on, if you learn something new and you want to share it.
Absolutely. Thank you.
That would be great. And again, it's Dr. Rye, and we're in Patchogue on Main Street right now, but he also has an office in Breakwaters, which is near
right between the towns of Babylon and Bayshore.
Yeah. I want to see that clinic. Yeah.
Yeah, come by. You'd love it.
And officially, you're the Rye Clinic. R-A-I, Rye Clinic.
Correct.
Gotcha. And in this office, he's also got PT, which Gary is phenomenal, and I see him. And it's all in one building. It's great.
That's right. We focus on improving patient outcomes. So we work together and we coordinate care between our providers. And we have a multidisciplinary approach, which includes many team members, including our doctors, our nurse practitioners, our physical therapists.
It's great.
Okay. So what we're going to do now is we're going to prep your skin for the injections. It's important that we want us to cleanse the skin as best we can.
Now you're going to go up here. Is this good enough to hold it? Is that far?
That's perfect. And I can help adjust, so we can always tape your shirt up if we have to. I'm going to cleanse the skin focusing on the areas that we're going to be injecting, and then I'll review the treatment plan with you. So this is the biceps, brachialis, brachioradialis, triceps, pectoralis.
Pectoralis. I like that word.
If we have to, we go up here to your trapezius. And this is just what we call ChloraPrep. It's a pre-injection, a pre-surgical cleansing scrub. Truthfully, it's not necessary. A lot of providers don't use this because these injections are just into the muscle. So usually an alcohol pad is sufficient. I'm a little neurotic about germs, so I share my neuroses with you.
Are you a germaphobe?
Quite a bit, yeah.
I'd love to see your house.
You don't want to see. Ironically, it's the messiest of the messy.
Well, you're all over the place. You have so many ideas. I can imagine things. You just leave things like me in piles.
Yeah, they say it's a sign of creativity.
Yes, my mind doesn't stop.
That's right.
And, I was thinking of the business and how we talked about
care coordination.
And I've been working on that. And I'm to the point where I'm trying to develop relationships with the hospitals and the rehabs and the nursing homes that you had talked about.
Yeah, great.
So that's where I am now with that. But I don't have any clients yet, but someday, soon.
Very soon. Yeah. Well, once give yourself a chance to recover from your knee replacement, you'll be high flying.
Well, since I wasn't moving a whole lot, it was good to be able to sit with my laptop and come up with ideas.
That's right. Yeah. Downtime to creativity is very important. Okay. So Diane, our MA, medical assistant, prints me our last note. So we have the treatment plan that we used last time. And now what we're going to do is we're going to review the treatment plan to discuss which muscles we want to continue to target and which we want to avoid targeting to give you back some of that tightness that you found useful. So we injected 7 muscles last time we did it. We did do the leg. Okay. Yeah. So we did about 400 units into your leg last time, which we won't need to do this time. Right. So we have 900 left. We can choose which muscles now in the left arm to target based on what the effect we want is going, what the effect we want to see. Okay. So let me first have you raise your arm up for me as high as you can. Good. Okay. Then bring it down for me. Good. Now do it again for me. Bring it up. So what I'm noticing is that you do have the ability to bring your arm over your head. Bring it up again. I do see that you're limited at the shoulder. Okay. So what I want to see is if there's any tightness in the shoulder that is causing you to have that restriction. Relax your arm now. Let me move it for you. And I can see here, I can see it and feel it, that this muscle here, the pectoralis, is very tight. So we do want to target that. Okay. Let me see here over your shoulder. If the trapezius, relax your arm. Your trapezius, or we call your trap, doesn't feel very tight to me. Yeah. Good range of motion there, and I'm not feeling the muscle go into spasm. Great. The way I did the pectoralis. So we don't need to necessarily target the trapezius. Your deltoid is good. Relax your arm for me. Relax. Yellow is so nice and loose. Real nice and loose.
I can't really straighten it all the way though. So I think that's more this area that needs
It's the bicep. The trouble with not moving your arm for a long period of time. Now, your stroke was in what year again?
2004. I had a stroke in utero, so I always had a left side weakness. So it was flaccid growing up, but since the aneurysm rupture, it went to a tight fit.
So this is interesting because the elbow is not terribly tight when I'm moving it. It has nice, good, loose movement. I don't, if I try to move it a little faster, I can sometimes elicit a little bit more tone, but even that I'm not really appreciating. The elbow doesn't fully extend. The issue is this may be what we call a contracture. As I put pressure against the back of the elbow, you feel it stretching, right? So with therapy, this is something that therapy may actually help with quite nicely. And then you want to bring the bicep and those muscles into a position of tautness or tightness, and then do a gentle stretch. And if you do this every day for a matter of weeks to months, you will notice a small improvement, step by step, incrementally across the elbow, and that may help manage that contracture. We can inject the bicep to help relax it further. My concern is I don't want to inject too much there because we don't want to weaken this muscle more than we have to, because that's going to result in weakness that I think you're you're finding difficulty with already. So we can inject a little bit to that bicep. What I'm noticing is this motion here. This is very tight. Okay. And this motion we call supination, like you're holding a can of soup. This motion is pronation. So if I can't supinate your arm, it usually indicates that your pronators are tight, the muscles responsible for this motion. So I'd like to target those. And there's two key pronators. I'm going to target the larger one here, pronator teres. Okay. You also have a pronator quadratus here, but I'll do the pronator teres because I can feel that tightness when I'm trying to twist here.
I feel that stretch.
Here you feel it. Yeah.
I feel it.
Also here.
Yeah.
We could try for the quadratus. So we'll inject a little bit into both of those. Okay. So far we have the pectoralis, biceps. I don't feel the triceps. I don't think we need to inject those. I don't want to do the brachialis or brachioradialis because again, I don't want to weaken the flexion across the elbow. Right. Pronators, definitely. Fingers.
Now that, interesting that my pinky's kind of giving up and it's going back in, but the rest of them
are in like almost a swan deformity.
Yeah. My little niece who's 10, my great niece, she goes, "Let me see your hand. It's so cute." She calls it a dinosaur. Yeah, that still kind of hurts.
Yes, this still hurts. Where does it hurt? This hurts.
No, this hurts in here.
In the fingers themselves.
Yeah, those are tendons that need.
Yeah, that needs stretching. And I think
that doesn't hurt right now.
But when I'm supporting it.
I do this when I'm sitting watching TV. I do those. I help it and then I turn it to stretch that like you did. But the wrist, I wasn't able to. I still can't do that, but.
Let me see. You try to bring the wrist up for me. Yeah. There's almost a full wrist drop. So I don't want to weaken any muscles along the back of the arm, which is responsible for bringing the wrist up. If anything, I want to try to weaken the muscles in the forearm here. Okay. And I can feel they're a little bit tight. Yeah. That are pulling down. So we will avoid the fingers. Okay. We're going to avoid the back of the arm. We're going to inject into the forearm. There's two muscles responsible for finger movement like this. And again, we'll go light on the dose. What I do notice is that your wrist is flexed towards towards the outside of your body, what we call laterally, which to me indicates that maybe the flexor carpi ulnaris or one of the other muscles here in the forearm may be a little tight. So I'm going to try to target that muscle as well. Okay. To see if we can loosen this wrist for you.
Yeah, that would be great. I had the same problem with the ankle. That joint. Yeah. It made it worse when I got run over by the car. Yeah, that's been a while. And Gary, when I was at physical therapy yesterday, he tried to stretch and he's like, I was so tight and locked in. He said the joint's locked. And he wasn't.
At the ankle?
Yeah, he was trying to get my toes up to the ceiling. And we talked about that, how I can't. I have very little motion in my foot. But the AFO definitely helps with the foot drop.
Correct. I'm doing a little bit of math here. It's simple math, but just to make sure I get it correct based on what we just spoke about in terms of how we're going to distribute the medication into each of the muscles in question.
Couldn't be a doctor because I don't do math.
Okay. So I'm just making sure that we distribute the medication properly based on the conversation we just had, based on what we just saw in terms of which muscles are tightest and where. And then what I do is I distribute the amount of medication, make sure that it adds up properly so that we know that we're using all of it so nothing's wasted. And then I use this as my template or my guideline or my roadmap, if you will, as to where we're going to be injecting.
You use the TENS?
Yeah, so it's a great topic to bring up. I use what they call guidance to help me guide my needle as to where I want to go. There's a number of different types of guidance you can use when it comes to injecting neurotoxin. Use what they call electrical stimulation. So that's where we introduce a little electrical pulse, like a zap, I call it, the muscle that we're putting the needle into to help us confirm that we're in the right location.
Okay, because it'll spasm a little bit.
It'll spasm, it's like a little twitch.
Okay.
Do you have any pacemakers or any electronic devices implanted? So if you did, or if you had a risk for seizures, forbid, we would likely avoid that type of stimulation. It's not an absolute contraindication, but it's usually discouraged.
Yeah.
So we would use one of the other types of guidance modalities. For example, you can use EMG guidance, which is basically putting a needle into your muscles. Now your muscles are electrical are electrical in nature. They receive electricity from your nervous system, and that's what helps them contract and move. So muscles at rest should not be moving. So there should not be electrical activity in muscles at rest. If there is spasticity, then that means that the muscle at rest is excited. It's receiving electrical impulse. So if we put a needle into that muscle, we can usually detect the electrical activity. And that's called EMG or electromyographic guidance. The third type of guidance that's available is ultrasound guidance. And a lot of practitioners these days are using that. It's also a very good guidance modality. You look for different things. It's not relying on electrical impulses the way this is. It's relying on ultrasound images that are created. And it's a very good modality. We have it here at the office as well. I'm most comfortable using this, and a lot of times provider dependent, whatever a provider is comfortable with and prefers, they use that. So we have all those modalities available here for our patients. So we're going to start with the injections. We're going to start
with the top. How big that needle is.
It's a very long needle, but it's skinny. So it
doesn't hurt me at all.
It's a very fine point needle, and I believe it's coated in silicone or Teflon, so it's bends, and it's also glides very easily, so it's minimal discomfort for the patient.
Now they use that for IVs in the hospital.
That's right.
That's the type of needle.
Right.
I don't know.
Yeah, actually the IV needles are even a little bit
longer,
stiffer than this,
and
thicker. So this is, like I said, minimally discomforting, I hope, for you.
Okay, no,
and you've tried it before.
I've been poked so many times.
Poked and prodded. Yes. So what I'm going to do is I'm going to position your arm on mine.
Okay.
And I want you to relax the elbow. I'm going to pull your muscle into a position of stretch. Try to stay shoulders square with me so I can feel the muscle. And I feel for the pectoralis based on its known anatomy. I grab it, we inject, and I feel for what I feel the needle go into muscle tissue. Yeah.
That's wild.
Good. We pull back on the needle to make sure we're not in any blood vessels. And I'm going to inject the predetermined dosing into the pectoralis. Done. I pull out, put a little pressure, a little massage to the area to get it to stop bleeding if there's any bleeding. I'll try to give a little gentle stretch or passive stretch to that muscle.
Does that kind of disperse the medication a little bit?
In my mind, it does.
Yes.
A lot of providers don't go to these lengths, but for me, I look at muscles like taffy or silly putty.
Mm-hmm.
The more you stretch them, the more you move them, the better. I try to take advantage of the fact that the needling, poking the muscle itself, helps to break up some of that tight tissue. The injection of the fluid that we just injected also helps to stretch the tissue. So anything we can do to take advantage of that moment.
You really feel that stretch. It feels good.
Good. Okay, looks great. Check for no bleeding, and you're good.
Yeah.
Okay, now relax your arm down. The trickiest part of all this is making sure the wires don't tangle. So that was the pectoralis. We're going to move now to the biceps. We're going to do 100 units to the biceps.
All right, I'm going to bring this down so you can really see.
Relax your arm, relax it. I'm feeling where I feel the tightest part of the muscle belly.
Sometimes I try to relax and it won't. Yeah, you barely feel that pinch. I feel it going in, but it's not painful. It's just like pressure.
Out the biceps, just keep a little pressure there.
Now, this, of course, is a smaller muscle. Now, when you first did my hand and wrist, I swear the next morning it was open.
I believe it. Yeah, I believe it. A lot of times, again, the medication works in the way that it works. So we finished one syringe. I'm gonna connect the next syringe.
That's so cool.
And I have this machine set to 3 milliamps. We can increase it. When you increase the signal or the amplitude, it can get you more of an impulse. I'd like to show the audience if we can get an impulse for you, but it also makes it a little bit more uncomfortable.
Go for it. I'm used to uncomfortable.
We'll go up a little bit. Let's see. Okay. For your pronator teres.
You trying to trigger it?
Okay. So if the audience can see your finger is moving.
Yeah. I wanted to tell you I got a TENS unit and I want to know.
So there's a twitch there.
Yep.
And that helps identify the muscle that you're in. You're saying that you got a TENS unit?
Oh, yeah. And I wanted to ask you, is it for pain? I thought it would help a little bit with, I don't know what I thought.
So there's, the TENS units are interesting. There's a lot of benefit to the TENS units. They help both with pain, and they can also help stimulate the muscles that you want to, kind of wake up a little. So
Okay.
It's actually multifaceted benefit.
I got a fancy one. It's Bluetooth, wireless, and rechargeable.
So I'm going to be poking around a few different muscles.
That one I feel.
You feel it? Where, in the fingers? Or?
No. I feel the poke.
So you see the way the muscles are moving in the fingers? I don't know if your audience can see the twitch.
Yeah, that forefinger's jumping.
Now I see the wrist moving, which is good.
Everything's connected, right? Now, where are you putting the most medication? Which muscle?
So I'm targeting 3 or 4 different muscles here in the forearm, and based on what I'm seeing with the twitch response, I'm advancing the needle, pulling it back, relocating to try to maximize the medication into the muscles that we're trying to target. Now, it's a little difficult because of how tight your pronators are. The positioning changes the anatomy somewhat, so you have to be a little creative sometimes in terms of how you get to the muscles.
Yeah, I was never in my life able to turn.
Even as a child?
Even as a child.
I'm going to try to get to the deep forearm muscle, the profundus, we call it.
Feel the twitching.
So I can feel how tight this muscle is based on the resistance to my needle.
That's crazy. It's very interesting. I'm a geek like that. I like to learn how the body works.
Of course. Last syringe.
Yeah, the fact that my wrist even goes like that, I was never able to do.
That's wonderful. I'm happy that we can bring it up. What we call passively, meaning I'm doing it for you. What I'd love to see is if we can get the wrist relaxed enough where maybe some of the inherent strength that you still have left in that wrist and that arm can help you bring your wrist up actively, meaning for yourself.
Yeah, right. The brace that I have from MyoPro or Myomo, that does that for me.
Is that right?
It reads that.
We're entering a whole new area of advanced technology that's available to patients. So, for example, Myomo, the MyoPro, in terms of what it can do.
Yeah, and that takes practice. So I got it a few years ago, but I wasn't able because my shoulder gave me a lot of pain, and I had surgery on my shoulder. And then they told me not to use it. And then, of course, with me, out of sight, out of mind.
Right.
And I didn't use it for a while, but now it was very difficult when my hand was tight like that. It would really hurt. Now I put it on and it doesn't hurt. So now I can actually practice more with it.
Good. I want to come back and try to get more into the pronator teres. We talked about the quadratus. Try the quadratus. See the fingers there. Now you see how that, you see that?
Yeah.
You see how it's, see that? Yeah. So you see the twitch?
Yeah. I feel it too.
Yeah, exactly. So we know in that muscle, which is great.
The whole arm is twitching.
It's such a great response. I'm going to inject there instead of going back to the teres. That's good. Hopefully that helps get that wrist open so you can get your palm up.
That's so amazing.
And that's it. We're done with the medication. We're done with the procedure. I'm going to turn off the equipment.
Awesome. And again, I barely felt it.
Beautiful.
No bleeding or anything.
I'm going to dispose of the needle. Take these little shreds off of you.
You know how many times I had surgery and they always forget?
Oh, I'm sure. And they show up a couple days later.
In the shower.
Yeah, in the shower on your shirt.
Yeah. It's on there stuck on my chest, and then I have like the glue on my skin.
Yeah. And then what I like to do is just to do a gentle stretch again of the area to try to maximize the effect of this entire procedure for you.
That's really
so try to, yeah. Kind of like an arm wrestle.
You would definitely want.
I don't know about that. Yeah. I look stronger than I am. I'm just going to try to stretch this forearm into pronation as best I can.
Yeah, I definitely feel that. So that'll loosen up.
It should, it should help to loosen this. Absolutely. Well, this is only, it's a multimodal approach, meaning we want to use all of the techniques available to us to try to maximize the benefit to these muscles and to you. So the needle itself helps to relax the muscle.
I really feel that.
Yep. The stimulation itself helps to relax the muscle. The medicine helps to relax the muscle, but the medicine doesn't work right away. The medicine works over the course of weeks. So it'll take a week to maybe 3 weeks to really see its effect. It'll peak at about 6 weeks. and then they'll start to wear off. That's how that neurotoxin works.
Oh, it's never really wore off on my fingers.
Right. Yeah. Well, in a sense, it's a good thing, but we want to, again, we're using a lower dose to help and bring some of that strength back. And the other advantage of having a loose arm is that any bracing, like the electronic bracing, the Myomo or the MyoPro, works better because now it doesn't have to fight against the tone or a spastic limb. It can actually work the way it's supposed to. The other thing I want to mention, which is what I'm doing here, is that really in the end, the mainstay of management of spasticity is range of motion, gentle stretching on a daily basis, and physical or occupational therapy. It's so important. So all of those things taken together, the medications, the stretching, the needling, will help to improve the outcome. And that's what we're focused on. We're focused on a good outcome to try to make the most of a bad situation. And I think we're well on our way.
Yeah, the third injection. So much.
Good.
Look at that. That hurt when we first did that. Now it doesn't.
Good. Again, that stretching is key. All right. All done.
Yeah.
All set. No bleeding. So you're good.
Yeah.
All right. Very good.
So we didn't do the leg, but normally we do the calf. And that's what I wanted to ask you. Since surgery, my left calf.
Maybe since the knee surgery?
Yeah. Yeah. It actually hurts down here, right in here. And I wonder why that is. Is it the surgical procedure and how they kind of right in there.
Right here. I feel the muscle is tight. You are walking, right?
Yeah.
You're moving again. Do they have you on blood thinner of any kind?
They had aspirin. I just stopped at 6 weeks.
Okay, good. There's no swelling in the leg that I'm noticing, correct?
Right.
Okay. So this is somewhat off topic, but related to the question you just asked. After knee replacement surgery, the main thing you worry about is swelling or pain in the calf that could represent what they call a DVT or deep vein thrombosis. Very unlikely. You don't have much appreciable swelling. There's no pain in the meat of the calf. There's just pain here on the outside of the leg, and I can feel the muscle band very taut. So that's what we call your gastrocnemius muscle. It's the lateral head of it, and it's very consistent with what you would expect after a total knee replacement, which is muscle tightness. Calf muscle, the gastrocnemius in particular, crosses the back of the knee joint. And because of that, any amount of immobility or any amount of pain in the knee that prevents you from moving it will likely result in that calf muscle getting a little tight over the course of weeks, which is what we're probably dealing with. The way we would address this is we do physical therapy and stretching, and we'd watch it. If the pain doesn't improve, you let me know and we can look further into it. I don't think we need to do any imaging. I don't think we need to do any ultrasound at this point. If you're very concerned, you can always go back and speak to the surgeon, but I think they would probably...
No, it's muscular.
Yeah.
They would have to stretch it more.
They would probably tell you exactly what I just mentioned, where stretching and therapy will be key for this. We can eventually, once the knee replacement's settled and you're back to your baseline, we can eventually inject some of this neurotoxin into the calf to help relax it. And get you to be a bit more comfortable if you need it. In the meantime, you're doing great. I think you're making great progress. Yeah, of course. Any questions?
No.
Great. If there's any questions from your audience, they can let you know and tag you or tap you or like you and let me know indirectly.
And I'll connect them with you.
Great. Very good. Very good. I'm happy to help.
What patients do you treat other than stroke patients? So
as a physiatrist or somebody who specializes in physical medicine, we treat any patients who have had catastrophic injuries, any patients who've had significant debilitating injuries. So, for example, many of my patients are stroke survivors with spasticity or weakness. I also specialize in the care of patients who have either lost limbs or at risk of losing limbs due to diabetes or peripheral vascular disease. So I take care of a lot of amputees. We also work with patients who have problems as common as low back pain, neck pain, joint pain, or arthritis. That's very basic rehab, but it's very important. Then I'm also a subspecialist in wound care. So the many patients are
I needed you for that.
Yes, and wounds are
my elbow.
Yeah, unfortunately, wounds are increasingly more common, and they can become very problematic if they don't heal quickly. So patients very often need a wound care specialist, and I spend a lot of my week taking care of patients with wounds as well.
And I didn't know that when I ended up with bursitis in my elbow and
Right.
infection. And then you look at it and you're like, all right.
Yeah, absolutely.
Yeah, I didn't know
So
that.
we
So that's great.
take care of a lot of different types of problems, and I'm part of a large group of excellent providers. And if we need if we need help taking care of a patient, we have a great team to draw on. Harry, and you've met our staff already, so you know how great the team here is.
Yeah. Thank you so much.
My pleasure. Okay. Great to see you. And I'll see you back for a follow-up in about 6 weeks to see how this round of injections helped.
Yeah.
Good.
I'll keep track.
Good.
Thanks so much.
You're welcome. You're welcome.
Thanks everyone for watching. I hope it was helpful. Bye-bye.